Morning, everyone. Last time we talked about acute coronary syndromes, and we talked about a continuum, its unstable angina and STEMI and STEMI, and we discussed each one of them and what it means in terms of timing and what to do. And if you remember, what I said is going to be any patient that we take to the cardiac catheterization lab, because we're doing this in that regards, is the pre-procedure, and then the procedure, and then post-procedure. And we discussed, so the pre-procedure is the diagnosis, which we all discussed. We talked about the pathophysiology, we talked about medications, we talked about findings, and so forth. And once we decide that we're going to take the patient to the cardiac catheterization lab, we have to make sure that certain things are ready. Of course, the number one in those patients in Virginia, if it's an elective or semi-elective procedure, meaning it's not a STEMI, you need to get the consent, and the consent is usually obtained by the cardiologist. It has to be the cardiologist, not anybody else, not the hospitalist, not the nurse. It has to be the cardiologist performing the procedure, or one of their colleagues. If they're a bigger group, one of the other colleagues can do that on behalf of that person. If it's a STEMI, in STEMIs we don't need like a written consent, we just need a verbal consent. And the patient has to say, we have to tell the patient that yes, you have to go to the cath lab. About 10 days ago, I was on STEMI at Reston, and they call me, there's ECG changes, the patient's having chest pain, and we rush. On my way, the cath lab tech says, did you take a look at the EKG? It might be, it might not be a STEMI. I looked at it, looked like more like pericarditis. The patient was a middle-aged man. And usually you can't tell if it's pericarditis or not. What we do is we take them, we do the cath. If it's negative, they can even go home. And the patient did not want to have the procedure. He said, no, I don't want it done. So we had to bring everybody in, just have them witness that the patient refused the procedure. You can't take that patient to the cardiac catheterization lab. Same thing, like 10 days before that, I get also called to Reston for a STEMI. And it was a real STEMI. It was an 80-something-year-old woman. And the patient was a DNR. So that's another thing. A patient with DNR, we don't take them to the cardiac catheterization lab. So if you know the patient's DNR, do not call. Because if we are to take them to the cath lab, this has to be reversed. Because anything can happen in the cardiac catheterization lab, and you're putting all the staff in jeopardy. If they get ventricular fibrillation, which is not an uncommon incidence in the cath lab, you cannot shock them if they are DNR. So the daughter wished that the patient observe that, like DNR, and we did not take the patient to the cath lab. So in STEMI, we don't need a written consent, we just need a verbal consent that they are to proceed to the cath lab after we discussed that. Other than that, we need a written consent in the chart. Then we have the pre-procedure orders, and those are important because they let us prepare the patient for the procedure. Especially important for those patients that have renal disease, because we're going to use contrast. And those are all in the pre-procedure order sets. All you need to do is just make sure that they are there. If a patient you know has renal disease, they should be getting fluids prior to the cardiac catheterization. The other thing is sometimes medications. We talked about medications like preloading them with antiplatelet therapy, or if they are on anticoagulation, usually we hold that on the day or like on call to the cardiac catheterization lab. So if it is heparin, this is important also to know. The heparin drip we hold on call. And if it is Lovenox, we also hold the AM dose. And the reason is because the interventional cardiologist wants to be able to load those patients accordingly with anticoagulants without the interference of something else being on board. And because we use a standard and the activated clotting time to guide us throughout the procedure. So this is the pre-procedure, and then the patient goes in, and then we go to the procedure. And the procedure we discussed, it starts with, if you remember last time, access, and then the cath minus plus PCI, and then access. And most of the procedures today are being done through radial access. It is like operator dependent. Some operators still do not do radial, they only do femoral access. But the majority of the country is moving now to radial access. Radial access is important. What we usually do, we go with the right radial. It's very important. We discussed that also last time. Conscious sedation is important. This is around the time of the procedure. The timeout is important. What I do is, as soon as the patient's ready, we call a timeout and we consciously sedate them. That gives them, it relaxes them, and it does relax the arterial system in them. So it is less spasm. So that comes here, which is the conscious sedation after correct identification of the patient, and which is all documented. Then we obtain the radial access with the sheath. There are different ways of doing that. One is the Seldinger technique, one is the modified Seldinger technique. I'll tell you about it like quickly. So the modified Seldinger technique is where you just go in, it's an anterior, this is the artery, this is the anterior wall, this is the posterior wall, is you just get into the lumen and then get a wire and then exchange and put a sheath over that wire and take the wire out. The Seldinger technique is where you go in and out like anterior posterior, and then you pull back this is the tip of the needle. You pull it back until it is in the lumen, and you'll see a little like red dot of blood here, and you remove it, and because it's a cannula like the ones that you use to obtain IV access, blood gushes out, and then we put a hydrophilic wire in and we exchange that. There are pros and cons to this. It's important to understand, especially if it is the like through in and throughout, because there is a puncture at this site. So sometimes a little hematoma can develop, especially if we use anticoagulation, antiplatelets in that patient. So this is the access. We'll talk about the access after. We talked about cardiac catheterization last time of what we do. We go ahead, we wire, we put the stent. We talked about the different types of stents, the bare metal stents. We talked about drug-eluting stents and why we use certain medications and for how long. And that's why we ask them, usually I ask them here, do you have any surgery coming up? Is it like a patient with breast cancer who's supposed to have her surgery like in the next couple weeks or 4 weeks? Then we go ahead and do a bare metal stent, for example, instead of a drug-eluting stent that will extend the antiplatelet therapy for at least 6 months. So we talked about that, and then we talk about access after, and that is removing the sheath and achieving hemostasis. And so there is a puncture here, whether it's in the femoral artery or in the radial artery, and we need to achieve hemostasis as we come out. In the radial artery, there is something called the TR wristband, and the staff in the cath lab usually apply it. They remove, remember I told you my drawing is not good. So they remove the sheath, and they apply the wristband on this, and they inflate it. And we need to know exactly how much or how many milliliters of air did it require for them to inflate in order to stop the bleeding. So they continue inflating until there's no more bleeding. They release a little bit until they see a little blood gushing, and then they go up by 2 milliliters of air. So we do two things: the time when this was applied, and then how much milliliters of air. Those are documented, and also there is the post-procedure. This all has to do also with the post-procedure. Those two things have to be entered, and they carry on to the nurse that is going to take care of this as it deflates in the next 1 to 2 hours. Usually, if it is just a regular cardiac catheterization diagnostic, we did not do any intervention, we did not give antiplatelet therapy, the time of deflation starts after 1 hour. So after like 60 minutes, they can start deflating. And what they do, there's a protocol. It's like the first time they take 2 milliliters down, and they look if everything is fine. They come back in 15 minutes, take another 2 milliliters until all the milliliters are out. Remember, this number of milliliters is variable. And then they keep it there for about, once everything is deflated, no bleeding, they keep it there probably for about maybe half hour, then they remove it, have the patient just move their hand. They're not supposed to use the hand extensively. I remember that one day also at Reston, we removed it. The patient was eating with their hand and then started bleeding. So they're supposed to let it rest and use the other hand that was intervened on. And then for 1 week, no more lifting of more than 5 pounds for that hand. They can, the next day they can drive. They can't drive that day because we usually give conscious sedation. They can drive, but no more lifting of more than 5 pounds. This is for the radial axis. For the femoral axis, what we usually do for femoral, we try to close, and there are different closure devices. This is the femoral. It's a larger artery. What we do is, if it is diagnostic, sometimes we do a 4 French, then we don't close. You have to remove it and apply pressure. And the pressure usually is applied in the cardiac catheterization lab for about 15 to 20 minutes until there's no more bleeding. And then the difference between this and radial is that the patient has to stay flat for at least like 4 to 6 hours, depending on the size of the sheath, if we had used any anticoagulation or antiplatelet therapy. And they really have to, they cannot get up. And many times we see that they do go up, they go to the bathroom, and then we get called, the patient's bleeding, and a big hematoma starts to form in this area. And then we have to do it all over again. So this is for the femoral axis. If it is more than 4 French, if it is more 4 than 5, or more than 5 even, a 6 French sheath, we can go ahead and close. And closure, there are different closure devices. Basically, they seal the point of entry either through like a fibrin that dissolves after a few hours, and then it continues to dissolve over the next few weeks until it's completely dissolved. Or through perclose, which is suturing the proximal and distal sites. And usually those take care of the problem. The patients can get up in those situations in 2 hours. They don't need to stay sitting or on their back for 4 to 6 hours. So this is the closure, and this is the post-procedure. All the orders now transfer to the nurse who's taking care of the patient, and the post-procedure usually have to do with IV fluids, with medications, and those are the anticoagulation. Usually we stop that in most cases. Sometimes if there's a clot in the coronary artery, we continue the heparin, and with the antiplatelet therapy, and with everything that we get monitored on. There are 5 medications that a patient has to have prior to discharge, and if they're not on board, there has to be a reason, and it is spelled out in discharge orders. Why is this patient not on antiplatelets, which is aspirin? They ask you. And then there is this weird thing in the HCA's orders, which they tell you, is the patient on antithrombotic? And I usually say yes, although they're not. And that antithrombotic, I interpreted in my own mind that it's the second antiplatelet, because otherwise patients are not supposed to be on antithrombotics with acute coronary syndrome after that. Antithrombotic could be heparin, or it could be intravenously, or it could be warfarin, or it could be one of the NOACs, the novel anticoagulants. So they have to be, if they had a stent, they have to be on 2 antiplatelets. The system does not give us that here. And this is like an HCA national system. It does not give us the second antiplatelet for patients who underwent stent deployment. And then it asks you about beta blockers. They have to be on it. And it asks you about a statin. They also have to be on it if they had an acute coronary syndrome. And it asks you about ejection fraction if it is more than 40 and less than 40. And if it is less than 40, they have to be on an ACE inhibitor, and it asks you about it. And you have to mention why not if they're not on it. So the patient's bradycardic, hypotensive, blood pressure is low, I can't use a beta blocker, or if the blood pressure is low, I cannot use the ACE inhibitor. So this is the orders for that patient. And then discharge orders. And discharge orders are already there. Those patients who it's diagnostic, they can usually go home the same day. And now, the more we're doing intervention, we're more comfortable. If it is radial, uncomplicated type A lesion, in the morning, we can send those patients home the same day in the afternoon. Those patients now are starting to go home in the afternoon. They don't spend the night. If it is femoral, it happened afternoon. And if the patient, the procedure was complex, then those patients have to stay at least a night. So this is the post-procedure. And now, let me remove this. We'll talk about complications. So there are complications that are related to the patient themselves, and there are complications that are related to the procedure. So if the patient, for example, has a chronic kidney disease, we have to pay attention for the status of the kidney post-procedure. Usually this does not show up. It has to show up, or it shows up not immediately post-procedure. It takes time to show at least 24 to 48 hours if there is chronic kidney disease for this to worsen, or it takes about 72 hours for something called contrast-induced nephropathy. It takes about 72 hours for this to show. So we are not going to see that if the patient has no chronic kidney disease. Usually what happens, patient goes home, they might not drink well, they might take something that is injurious to the kidney, and they show up in the ER probably 3 to 4 days later, and the kidney function, it gets checked, and it has worsened from before the procedure. This is contrast-induced nephropathy. Usually we treat it, it's self-limited, it's treated with fluid, and it recovers usually completely. So this is related to the patient. Patients with chronic kidney disease, we have to treat them pre-procedure with fluids. There have been a lot of trials where they have tried different medications, diuresed them before, diuresed them after. The thing that works always is fluids, is to get those patients on fluids. And that's why it's important to start the fluid pre-procedure. Sometimes we start it the midnight before, and sometimes we start it on call to the cath lab and in the cath lab, and make sure that the patient is receiving intravenous fluids, because that does help reduce the chronic kidney disease. If the creatinine goes up and it's more than a certain amount, then we get reported. So that's an incidence to report. That's as a complication. So that is one of those. The other thing is the hemoglobin. If it falls. if hemoglobin falls more than 25% from the initial hemoglobin, pre-procedure hemoglobin, then this is also reportable because this could signal bleeding. And so that is important. That is why now in Reston we're getting dinged on that a lot. We're going to start obtaining a hemoglobin at the time of the procedure. So just before we start anything, we're just going to send it, the first thing, get access, and then send the hemoglobin, because that is going to be the hemoglobin that is reflected in this. Because what happens is the patient comes in, usually a patient with a myocardial infarction, they sweat, they vomit, so they are heme concentrated. And then what do we do? After we start the procedure, we give them fluids. So the heme concentration turns into heme dilution, and the hemoglobin can fall normally. And then we're getting dinged on that, and we have to get ourselves out, so stating the patient did not have a GI bleed, they did not have a groin bleed, they did not have a retroperitoneal bleed. It was just hemodilution of their compared to their heme concentration before that. So those are the things that relate before. Now the procedure. And remember, the procedure involves, as we discussed, obtaining access, and then in the artery, this is the radial or femoral. This is the coronary. We do the procedure and we put a stent in. And this is after, which is the radial or the femoral. So complications regarding these are important to diagnose. The first thing we discussed, if you remember last time, the most important complication that could happen immediately after the procedure was acute stent thrombosis. And we discussed that in detail, so I'm not going to talk about it today. Acute stent thrombosis is stent thrombosis from the time the stent was deployed for 24 hours, the first 24 hours. And usually there's a clot. We'll just go quickly. There's a clot here, and usually it's an ST elevation myocardial infarction. We have to rush the patient back, go in, and get that thrombus out and see why the patient had acute stent thrombosis. Is the stent under-deployed? Is there a dissection that was missed? Or many other things. So this is regarding the vessel. And usually it's, again, chest pain, patients having still chest pain, and what you do as the nurse, you ask the patient, what is this chest pain? Is it the same? If they tell you they're still having remnant, it's much better than before, that can be dismissed. If they're telling you no, the chest pain is increasing, then the first thing to do is go ahead, get an EKG, and let's look at the EKG to see if there is any further ST elevation compared to the ECG that was done before. And that is why one of the first things we do after the procedure is obtain an ECG, just to make sure that the STs have returned back to normal. What happens is sometimes, and most of you know that, when we put a stent in, so what the stent does, this is the artery, we dilate it, and then we post-dilate it with a non-compliant balloon. It stretches the artery. So there's this pain that they tell you here that I can feel this pain. It's not like that one. That's a stretch. If the EKG is normal, no more ST changes, then that is a stretch. It's going to last for 2 weeks. It will go away, and we treat it with Tylenol, not with ibuprofen, not with NSAIDs, because there's a myocardial infarction. We don't use those in the first like 6 weeks even after the myocardial infarction. So this is the stretch pain. So just so that you compare, and it's good to obtain the EKG, call the cardiologist. The patient's still having this pain. It's much better than before. And then we just go ahead and we reassure the patient. We don't take the patients back to the cath lab if there are no new ECG changes. So then we'll talk about the most important sign after a procedure that can signal something important is hypotension, is low blood pressure. And what are the causes of this? Low blood pressure. So why would a patient post-cath have low blood pressure? Or you're called to see your patient because the patient, they look pale, and of course they're on the monitor, and you look and you see their blood pressure 65/40. What do you do? This is the most common thing or most important thing to recognize, because there's a million things that can cause low blood pressure in that patient, and we need to work fast through this algorithm to make sure that the patient's not having one of those serious complications that are reversible or that we could treat and save the patient. So one of those things, okay, so tamponade is one, because as we work through the procedure, it is very possible that we go inside the little coronary artery and we perforate it, although usually this is something that we know beforehand, meaning that the cardiologist knows they perforated the artery, they pulled the wire out, they like tamponaded the vessel with a little balloon, and they made sure that everything was gone. There's no more bleeding spilling into the pericardium, causing pericardial effusion and tamponade. This is the case. However, sometimes it gets missed, and the patient might have some little perforation that got unnoticed, and it leaked into, this is the heart, and this is the artery that got fixed, for example. And little perforation can happen here, and then it leaks into the pericardium, and it causes tamponade. So how do you diagnose it? If that is the case, yeah, echo, like stat echo, and the echo technician will be able to tell you on the spot if the patient's having tamponade or not. So, and usually this is an emergency procedure. Patient has to go back to the cath lab, and we have to drain the pericardial effusion. Luckily, this is rare, because it happens in the cath lab, and we anticipated, we've seen it, we've fixed it. Still, the patient could develop pericardial effusion. What else? A bleeding. Okay, that is the most common, is a bleed. So low blood pressure is bleeding, if it is very low. Where's the bleeding? I can't hear you. Site. So usually which site? Groin. Usually it's the groin. So if there is a hematoma in the groin, a large hematoma that can cause it, or, so this is the anterior wall, so the hematoma develops in this area, or sometimes if the stick is high, it can bleed into the retroperitoneal space. So, and that's important to recognize. Usually the hematoma, you'll be able to see the patient's bleeding, and you apply pressure on, try to stop the bleeding, and we stop usually if there's heparin going on, if there's aggrostat, glycoprotein 2B3A inhibitors going on, we stop those. The medications that we don't stop if the patient had a fresh stent are the aspirin and the Plavix, or the ticagrelor, or the prasugrel. So that is this site, and then we obtain an ultrasound to see if there is any like vessel-like type of rupture. If there is, we have to call the vascular surgeon. The vascular surgeon will take care of this. We type across the patient, we treat them as if it's a bleed. If the stick is high, there's something called retroperitoneal bleed. It's hypotension with abdominal pain, or like flank pain. So anytime you have hypotension with abdominal and flank pain, you have to think of retroperitoneal bleed in the setting of like a groin stick in a patient who underwent cardiac catheterization. Treatment for this is fluids, type and cross, maybe give them blood. That's the treatment. It rarely involves going in and fixing anything, because it's self-limited. If we recognize it early, to go ahead and do anything to fix it, because usually the bleed happens for some reason. As the anticoagulation wears off, the bleed seals itself, but it's important to recognize it because this can kill the patient. Retroperitoneal bleed is a lethal disease if it is not recognized early. If we transfuse the patient, give them fluids, and they're needing presses and they're still hypotensive, we can call, or we can even call them early, the vascular surgeon, because the vascular surgeon can go, and if there's a big rupture or perforation, they can go ahead and fix it, either interventionally or surgically. All right, so we talked about bleeding. What's the third type of bleeding in those patients? So we said retroperitoneal, a hematoma, or most common bleeding? GI bleed, right? Most common, right? So first thing comes to mind when you have a GI bleed is, number one, you check the groin, there's no hematoma. You ask them, is there any back pain, abdominal pain? You feel the abdomen, it is soft. So it's unlikely retroperitoneal. It can still be GI bleed, but it had not manifested itself, but it will manifest soon. And it will manifest with hematemesis, or it manifests later than soon with like lower GI bleed that you see. But it's important to understand that and to go ahead and treat it with also fluids, type and cross, like you're treating a GI bleed. The only difference in those patients is we cannot stop, if we put a stent, the antiplatelets. We cannot stop the baby aspirin and the Plavix, ticagrelor, or prasugrel. We have to keep it, because if we stop it, what will happen? The stent will thrombose. So that's why we cannot stop it. We can stop everything else but those two medications. So this is the most important, which is low blood pressure. One more thing about low blood pressure. So it's not a GI bleed, it's low blood pressure, and you know it is not a bleed. So we've excluded a bleed, and the patient is still having low blood pressure. Another cause in those patients, what did we give those patients in the cath lab? Could be sedation. So sometimes sedation can give us a little bit of transient hypotension. Usually this responds nicely to fluids. Sometimes we have to use a little low dose of inotrope, dopamine for example. But that's not the case. It's not the conscious sedation. What else can cause that? You look at their skin, and their skin is red and they're itching. You listen to their lungs and they're wheezing. So what is this? It's a reaction. What kind of reaction? Anaphylaxis to what? Contrast. Okay, so contrast is the most common. Another medication usually doesn't cause anaphylaxis like right away, but contrast in some patients causes anaphylaxis, and it's very important to differentiate. It's low blood pressure, it's skin changes, and bronchospasm. What do you do for those patients? Once we have that idea that we have to go ahead and treat it, what do we give them? So we can go ahead and give them, like, it depends on how low the blood pressure is. If the blood pressure is really low and the patient looks like we're just losing them, just use epinephrine. That's the only thing that's going to stop this cascade. So epinephrine, and then antihistamines. We give those patients to stop it. And after that, we can use steroids if it continues. And most important, you go to the system and you change their allergies, contrast allergy, anaphylaxis, so they don't get it. Because that patient, believe it or not, they can get some other test during this stay in the hospital that can involve contrast. So this is low blood pressure. So we discussed the access before and after. We discussed bleeding. We discussed low blood pressure and all its manifestations. Anything else that you want to discuss? Anything else? We went through everything.
I wanted to ask you, if the patient is on heparin before the procedure,
Yes.
how long before the procedure should heparin be stopped?
On call to the cath lab. So when you get the call from the cath lab, patient's ready, yeah, ready, just go ahead and stop the heparin. And what we do is, as the patient comes down, the first thing we do once we obtain access, we get an ACT to measure their, and usually it's normal, if it's just a regular drip. Anything else? I think we went through everything on the list. Another thing is here is in that hematoma patient, we obtained the ultrasound. Once there's a hematoma, we discussed it could be hypotension, bleeding. We obtain ultrasound, and if it's just a hematoma, then there's nothing else to do as long as the bleeding has stopped. Sometimes there's something called a pseudoaneurysm that has developed. Usually, this doesn't develop right away. It's not like an acute type of thing that happens. It develops with time over the next a few hours to few days. Sometimes it shows up on follow-up, where the patient's having a little bit of pain. And basically is that in this area, it's just like there's just a pseudoaneurysm, and it just continues to grow. And we measure that pseudoaneurysm, we measure this neck here, and if that neck is small, then what we could do, we send them to the radiologist. They do ultrasound compression to seal it. If this neck is larger, then they have to go to vascular surgery. Sometimes if it happens within their hospital stay, and we can go ahead and also counsel vascular surgery. They inject thrombin in this pseudoaneurysm, and it just stops it and seals it. This is done during their hospital stay at times.
Sometimes it seems like they'll have a lot of pain, and just it can kind of be like that it's stable. So like the groin's still stable. You might feel like a slight hematoma in there, but the patient wants to complain of so much pain, they won't want to ambulate, they won't want to get up, they don't want to stand sometimes because they're just having pain to the site. So from a nursing perspective, is there any other patient teaching or tricks that you would want us to do with those types of patients?
Usually, I do not give any opioids to those patients. I give them only Tylenol. The only time I use narcotics is in the cath lab, but nothing gets out of the cath lab goes with the patient to the holding area or to the stay area. If you think everything is fine and it's not proportionate to the type, then it's just educating them that this should get away. Sometimes they have back pain and before coming in, and they're lying on their back, and it's going to be for 4 to 6 hours, and they can get real pain. So the only thing to do is really sometimes is we could raise the bed up like 30 degrees. That helps them a little bit. The only thing is trying to maintain that the seal remains, that there's no bleeding. Giving them the Tylenol, reassuring them that once they get up, it will be better. Are you talking about after the 4 to 6 hours? They don't want to get up? I don't know. This is I've not like seen such a patient yet that does not want to get up. The ones usually they're dying to get up because of the back pain. They just want to move in their bed, and it's more likely that they move and it causes the bleed, and then it starts that cascade of resealing or restopping the bleeding. But if you see one of those patients, let me know what you would do so that I would learn like what to do if I see one.
Yeah, just the coaching, because sometimes it's actually getting them up makes them feel better, and they'll be like, no, there's like a little bump there, and I'm like, no,
Yeah, another thing is to tell them, and I tell my patients that, if it's femoral, there's going to be a bump, and there's going to be bruising, and that bruising is going to last 6 weeks. You tell them that, especially if it's a lady, that she's going to have bruising, but most importantly, it'll go away. And then they're ready for that 6 weeks of bruising. Because what happens, they go home, and then within 24, 48 hours, this whole thing becomes blue, and when she comes back, she's angry at you. It's like, it's because she didn't know about it. If they know that this is going to happen, and then it's different, and that is why it's important to when we remove the sheath, let it bleed out a little bit before we close it. One trick I used, like I learned, I was in my fellowship at a VA, and we needed to remove the sheath, and there was this older lady nurse. And we used to go ahead, and that was one thing. We're talking about the late 90s. The fellows did not want to do this because it was excruciating. You have to do it for 25 minutes to 30 minutes, and after that, your fingers are you have to open your fingers to do that, because of that. So she said, "Let me teach you one way of stopping that." We used to call it the fellow seal, not angioseal. So the fellow seal, we have to do it. So if this is the head of the patient, and this is their right side, and we go through here, she said, all you need to do is this is the sheath, just go up like a finger above, just put your fingers, just do this, yeah, just remove it, yeah, just hold it. And I was stunned. It's like, it worked. It's like, there's nothing. You don't need to put all your pressure on the patients like you're doing something. It's very easy, and you don't need to do the full 25 minutes and 15 minutes. This is because you are at one point, and you're applying all the pressure there, and your fingers are going to be fine. And it worked, and that's how I do it if I need to do it from that day on, from what she taught me. Anything else?
It's 2 o'clock in the morning. We're pretty sure it's the post-procedure chest pain. Would you rather us just call you? What is your...
Call me.
Call you. Okay.
Don't worry about calling. Okay, you call whoever you need to call. If it's 2 o'clock, 1 o'clock, at afternoon, it doesn't matter. So you just need to call if you think that you need to call. So you will use your judgment as well. So if it is the same, the pain is getting better, then the pain is getting better. But if there's any change in the pain, if it's going up, if it is not getting better, but before you call, just, for example, do an EKG. So because what will happen is the cardiologist is going to tell you, please do an EKG. So just do an EKG. You have that in your hand. Take a picture of it without the identifying information. You can text it to the cardiologist, and so that they can take a look at it to see what is going on. So all those, but by all means, you call who did that procedure. Okay? Anything else? Dr. Moquette, you want to add anything?
No, I think you covered everything.
And sometimes if there's a patient, and this is what we're going to do here, sometimes the interventionalist does the procedure and rushes to another hospital. And you have the patient is not doing well, and you see another interventionalist. Grab that other interventionalist to help you, and see if they could do things. It's happened to me also at Reston. I was there reading echoes, and the interventional cardiologist had just left, and the patient they were still in the cath lab and became hypotensive. They came and talked because they couldn't get a hold of that cardiologist. I came and I did stabilize the patient in those. It's important for them, the cath lab staff, they know what to do, but it's important for them to get reassurance of we're doing the right thing, we've started dopamine, we've started this, and we're type and crossing, we've talked to another physician. It was a groin axis problem, it was a hematoma. And we've talked to the vascular surgeon, they're on their way, and that patient ended up going to the OR and getting grafted because of clotting and hematoma and everything in that area. So if you cannot get a hold of the interventional cardiologist for some reason, and you see someone else, ask them to, and I'll tell you that I would, if you want to ask me about someone else, that is fine. If you want to ask someone else about my patients, you can't get a hold of me, same thing. And I don't know if it's for your patients. Yeah, so it goes, just, it's most important is the patient at that time. Because we do things that could make us lose the patient, and that's the last thing we want to happen, is losing the patient. Anything else? All right, very good.